Alright, chapter 29, burns. This is going to be pretty, it's only 88 slides, so it'll be pretty straightforward. We're going to go over the anatomy of the skin, pathophysiology of burns, and classification of burns. Alright, EMTs, Ariana and Beal have responded to a 62-year-old woman who lit a cigarette in her car while receiving oxygen by nasal cannula. The patient is awake, sitting up, with burns to the face, neck, hands, and forearms. Patient's hair is singed and she is coughing. What's going to be your priorities in managing this patient? Airway. What factors are going to help Bill and what's her name determine the severity of this patient's burns? Huh?
Depth of burn.
Depth of burns. Okay. Alright, risk factors for burn injury include extreme in age, 64 years, and greater than 64 years, and kids. Alright. Body temperature regulation is a significant concern in burn patients, and understanding the types of burns and how they affect patients. Alright. Alright, layers of the skin, epidermis, dermis, subcutaneous layer. Skin is your largest organ. The skin serves multiple functions. It protects against water loss, provides temperature regulation, provides a physical barrier against entrances of undesirable substances such as microorganisms and environmental toxins. Protects underlying structure and organs such as against mechanical shock and forces applied to the body. Provides insulation and protects the body from extreme environmental temperatures. Protects against UV light damage. Provides sensory perception. Aids in the elimination of some of the body's waste. And provides a biochemical process such as the production of vitamin D. By preventing further contamination and by providing the proper emergency care for the airway and protection from further injury, you can decrease burn patient morbidity or mortality considerably. What do most burn patients die from?
The airway.
In the pre-hospital, it is airway. Alright, in the hospital, what do you think it is? Infection. Alright, burn shock, which develops only after the first few hours, results from extensive vascular bed damage that allows both fluid and protein molecules in the plasma to leak into the surrounding tissue. The loss of plasma proteins causes the normal fluid balance of the rest of the vascular system to become disturbed, and as a result, blood plasma starts to seep from all capillary beds, even those not involved in the burn itself. This fluid shift causes hypovolemia. If lung tissue is involved, the damaged alveoli may allow water to seep in, disturbing gas exchange and causing acute respiratory distress syndrome, such as ARDS. Some of the toxic gases that can compromise your respiratory are cyanide, carbon monoxide, sulfur dioxide, and hydrogen chloride. Waste from cell destruction, such as myoglobin from the muscle destruction form in the blood, and a blockage in the kidneys can result. An extremity burn can cause loss of function, long-term muscle wasting, and joint dysfunction. Nerve endings can be destroyed as well. Although it is a low priority for the EMT, the GI system plays an important role in the long-term care and survival of severely burned patients. Burns are classified according to the depth of injury. You have first degree, which is superficial. Second degree, partial thickness. Second degree has the bubbles, okay? And full thickness is third degree. They will have a blackish color to their skin. It depends. Electrical injuries can result in fourth degree burns. Alright. Alright, first degree involves only the epidermis. Second degree is superficial partial is thickness, and then you have deep partial thickness. Alright. Full thickness is the third degree, and they will have eschar, which is tough, leathery, dead, soft tissue. Alright. here's your classification by a visual. Alright. Superficial, you're going to have that red skin or first degree. You're going to have red skin, painful sight, tenderness, and no blistering. Partial thickness or second degree, you're going to have blistering, intense pain, white to red skin, and it be moist and mottled skin. In third degree, it's going to have a leathery appearance, have charring, dark brown or white. Skin is hard to the touch. They have no pain because the nerve endings have been burnt.
Have you seen somebody that burned?
Huh?
Have you seen somebody that burned?
Yes. And pain at the peripheral of the burns. Alright? There's your superficial. This is your second degree. Still second degree. And this is full thickness.
I feel like second really first.
Full thickness burns covering more than 10% of the body surface area are considered critical. Huh? Probably iodine. Full thickness burns involving hands, feet, face, ears, eyes, and genitalia are considered critical. Critical burns, full thickness burns involving the hands, feet, face, eyes, ears, or genitalia. Burns associated with respiratory injury. Full thickness burns covering more than 10% of the body's surface. Partial thickness burns covering more than 25% of the body's surface in adults. Partial thickness burns covering more than 20% of the body's surface in children less than 10 and adults greater than 50. Chemical burns are high voltage electrical burns, burns complicated by fractures or major trauma. Moderate burns in young children or elderly patients are circumferential burns to any body part such as an arm, leg, or the chest. Circumferential burns which encircle a body area such as an arm, a leg, or the chest, especially ones that encircle joint areas, are critical because of the circulatory compromise and nerve damage that potentially can occur. Partial thickness circumferential burns or full thickness circumferential burns can lead to compartment syndrome from the edema collected beneath the burned area. This is when they go in and they cut the skin. It's called an eschorotomy. And they'll cut the skin to relieve that pressure. Pre-existing cardiovascular, pulmonary, endocrine, or neurological diseases can turn a minor or moderate burn into a critical condition in an elderly patient because of the body's inability to adequately respond to the stress. The estimate of burn injury severity is crucial in deciding on the facility to which the patient will be transported. I don't know if there's a burn center anywhere around here. I know there's one in Jackson at CMMC.
There's one in Shreveport.
Is there? Okay.
Which degree burn is that in?
Alright. Here's your American Burn Association classification based on body surface area. Alright, burns associated with respiratory injury are considered critical. That is not a mustache. That's probably where a mustache might have been. But however, it is burned it off. And those particles that you are seeing would need to lead you to a high index of suspicion of respiratory compromise.
Like the inhaled ones burn?
Probably. Alright, classifying burns by burn size. You can the rule of 1 can be used with patients of any age, but it is most useful in cases where burns cover less than 5% of the body surface area. Alright? The rules of 9 is a standardized way to quickly determine the body surface area percentage of a burn. Okay? These percentages differ in children and adults. Alright? And the patient's palm, not your palm size, the patient's palm, if you're using the rule of palm, equals 1%. Alright. Types of burns. You can have thermal burns are associated with heat applied to the body. Inhalation burns are associated with high temperature air or steam that is inhaled and causes damage to the mucosa or the upper airway. Chemical burns are produced by acids, alkalis, and other heat generating chemicals. Electrical burns result from resistance to electrical current flow in the body. You have radiation burns, which occurs from the absorption of radiation into the body. Flame burns. The patient comes into contact with an open flame. The clothing may ignite, causing further burn injury. Natural clothing fibers typically burn, whereas synthetic fibers usually melt, causing a contact burn in addition to the flame burn. Contact burns occur from contact with a hot object. The burn is normally localized to the area of contact. An example is touching a hot exhaust pipe on a car. Scald. Contact with hot liquids cause scald burns. The more viscous the liquid, the more severe the burn. Then you have steam. Hot steam causes severe burns. These burns are more often severe than flame burns because of the steam's high heat capacity. Typically, these types of burns are found in industrial accidents or in those who inappropriately open a car radiator while it's still hot. Hot gases can cause upper airway burns. Alright, however, it is not likely that the hot gases cause distal airway burns. Electrical burns. Because bones, muscles, and other tissue offer resistance to the electrical energy passing through them, the byproduct is heat, which results in internal burns. With an electrical burn, the clothing can ignite, resulting in a flame. Then you have flash burn. This is the type of flame burn, but it is a result of a flammable gas or liquid that ignites quickly. Areas of the body are covered by clothing normally are not burned. Inhalation injury can occur if the flash occurs in a closed space. Do not keep the burn immersed in cool liquid. Alright, this can cause hypothermia. You want to cool the burn down for 60 to 120 seconds only. Do not attempt to remove adhered portion of clothing because this might cause further damage to the soft tissue. You want to remove jewelry, however, okay? To complete the primary assessment, assess the patient's circulation and determine whether the patient is a priority for transport. Make a rapid estimate of the severity of the burn, taking into account the body surface area percentage and any information you have gained about the burn source or agent, and any information about the patient's age, medical condition that you have gained from the bystander or the patient themselves. In addition to your regular history questions, you need to ask, how did the burn happen? What caused the burn? Was the patient exposed to an explosive or other significant mechanism of injury? Did they lose consciousness at any time? Was the patient confined in an enclosed space, or did they inhale copious amounts of smoke? How long ago was the patient burned? What care did bystanders give the patient? What chemicals were involved in the burn, if applicable? If the burn was a scald, how did it happen? If a scald or burn injury involves an infant, child, or elderly patient, you need to consider the possibility of abuse. Does the patient have any history, significant history of heart disease, pulmonary problems, diabetes, or any other condition that might increase the severity or complicate the treatment? Signs indicating possible inhalation injury. You will have singed nasal hair, facial burns, burn specks of carbon dioxide in the sputum, sooty or smoky smell on the breath, respiratory distress accompanied by restriction of the chest wall movement, restlessness, chest tightness, stridor, wheezing, crackles, difficulty in swallowing, hoarseness, cough, and cyanosis, sore throat, the presence of burns on the oral mucosa. Alright, Bill and Ariana are concerned with the mechanism of burn since the patient was in an enclosed space and the gas that ignited was in contact with the respiratory system. The patient is coughing, has a history of medical problems requiring supplemental oxygen. In addition, they are concerned by the location of the burns on the face. They estimate the burns to be both superficial and partial thickness, and that they involve about 15% of her body surface area. Would these burns be classified as minor, moderate, or severe? I would go with severe as well. What criteria is present that would support transporting this patient to a burn center? What about our underlying medical problems? That would also be another case for going to a burn center. Alright, emergency care. Remove the patient from the source of the burn and stop the burning process. Do not ever enter an unsafe environment. Do not remove adherent materials from the burn. Brush away dry powders before flushing with water and remove the smoldering clothing. Also take off any jewelry stuff. After the patient has been removed from the source, you can stop the burning process by using water or saline. Remove any smoldering clothing and any jewelry. If clothing remains adhered to the patient, cut around that area. We don't want to make things worse. You need to pay attention to evidence of inhalation injury to the patient's upper airway. Alright, we need to maintain an adequate airway, adequate breathing, and oxygenation. They need it, breathe for them. Give them some oxygen. Classify the severity of burns. Take into account the body surface area, source, location, patient's age, and any pre-existing medical conditions. Transport patients with critical burns immediately. No ointment or salve should be used in burn care because they make inspection and debridement of the injury more difficult. You want to cover these with a dry, sterile dressing. Okay? Why don't we want to use water? It can cause hypothermia. Okay? You're not putting anything on there, any kind of antimicrobial, antibacterial cream, nothing like that. In dressing a burn, avoid using any material that sheds or leaves particles because this can further contaminate. Never apply any type of ointment, lotion, or antiseptics. This can cause heat retention. Never break or drain blisters. This can cause further contamination and the potential for fluid loss. Alright, these need to go to a burn center. Alright, inhalation, partial thickness greater than 10, full thickness, any age group, burns involving hands, feet, face, genitalia, perineum, or major joint, electrical burns, chemical burns, pre-existing medical conditions, any burns that coincide with trauma. If trauma poses the greater risk, they might need to be stabilized at a trauma center first. Children with burns in medical facilities do not have the proper personnel or equipment to treat burned children. Okay, they need to go to a burn center. Burn injury to a person who requires special social, emotional, or long-term rehab intervention. Determine whether the burn is thermal or chemical. If thermal, apply a dry, sterile dressing to both eyes to prevent simultaneous movement of the eyes. Chemical burns should be flushed with copious amounts of water while en route to the hospital. Flush the eyes from the center to the outside because we don't, if one eye is contaminated, we don't want to contaminate the other eye. Do not ever attempt, Yeah. Separate toes with dry, sterile dressings. You want to separate fingers as well with dry, sterile dressings. Alright? If the patient has a thermal burn, apply a dry, sterile dressing to both eyes to prevent simultaneous movement of the eyes. Continue evaluating the airway, especially if there are burns to the face. Swelling or closure of the airway can be rapid, and emergency medical care needs to be accomplished quickly. As with other burn emergencies, never enter an unsafe scene. Chemical burns can involve a hazardous material incident that you might not be prepared to handle, and you can become exposed. Brush off dry chemicals like lime prior to flushing with water. Always ensure that the chemical is one that can be diluted with water. Most industrial sites have those MSDS sheets or equivalent resource to discuss the handling of chemicals. Industrial sites have those that should be available. Just look up whatever they got burned with. You can also call poison control. They can help you with this as well. Minimize further wound contamination by making sure fluid runs away from the injury and not towards an uninjured area. Alright, when dry lime mixes with water, it produces a corrosive substance that can burn the patient. Therefore, it is more important to first brush off all the lime. After the lime has been brushed from the body, all contaminated clothing has been removed. Use large amounts of water to flush any residual lime that might remain on the body. Hydrofluoric acid is used in the process of etching glass. This chemical has the capacity to penetrate the skin and cause a delayed burn reaction. The patient might initially have no signs or symptoms. Regardless of the patient's signs or symptoms or lack of signs and symptoms, flush the area with large amounts of water. Carbolic acid can cause severe burns because it is quickly absorbed into the skin. In addition, its vapor is highly toxic and inhalation can cause respiratory compromise. Carbolic acid can be flushed with isopropyl alcohol followed by large quantities of water. Sulfuric acid can react with water and produce heat. Therefore, it is not necessary to use large quantities when flushing sulfuric acid. When dry lime mixes with water, it produces a corrosive substance. Alright, make sure you get all of that off as much as you can. Chemical burns should be flushed with copious amounts of water en route to the hospital. Alright, electrical burns. Never attempt to remove a patient from an electrical source unless trained and equipped to do so. If you do attempt to do this, what's going to happen to you? You're going to get electrocuted too. Never touch a patient still in contact with an electrical source. Once the patient has been removed from the electrical source, establish and maintain a patent airway and adequate breathing. Administer supplemental oxygen if needed. Administer supplemental oxygen if the SpO2 is less than 94, the patient complains of dyspnea, or the patient exhibits signs and symptoms of respiratory distress, hypoxia, hypoxemia, poor perfusion, or heart failure. Monitor the patient for cardiac arrest. Cardiac dysrhythmias are very common after a major electrical injury. Be prepared to administer CPR and apply an AED if the patient deteriorates to cardiac arrest. Assess the patient for muscle tenderness. Assess with or without twitching and seizure activity. Always assess for a source, which is the entry, and a ground, which is the exit. All the tissue in between is suspect for injury, even if it is not readily visible. Emergency medical care for source and ground injuries is the same for other thermal burns. Transport the patient as soon as possible. Most electrical burn injuries have a slow onset, and underlying tissue or organ damage might not be readily apparent. These patients should assume to have critical burns, even if the burn appears to be insignificant. Alright. So the entrance is through the hand and the exit is through the foot. It's going to take the path of least resistance. Alright? It goes up to the shoulder, through the heart, and out down the foot. This here is an entrance and exit wound for a electrical burn. Doesn't look like a whole lot, does it? Alright, this is partial to full thickness burns to the leg from a high tension wire. This patient was trying to steal copper wire from a transit power station and struck a high voltage line. You always want to assess for a source, which is your entry, and your ground, which is your exit. Alright, scene size up. Always BSI scene safe. Pay particular attention to your own safety. You want to look for burning structures or materials, chemicals, electrical sources, confined spaces, burned clothing, obvious burns to the patient's body, evidence of explosion, other blunt or penetrating trauma, Look for stridor or crowing from the upper airway. Obvious burns to the body and clothing, burns to the neck and face. Singed hair, nasal hair, eyebrows, other facial hair. Alert to responsiveness, airway. They can have stridor, or edema to oral mucosa in the tongue. Burns around the face and the neck can also interfere with your airway. Inside the mouth also interferes with your airway. Breathing, normal to increase if airway or respiratory tract is not involved. Increase or decrease, labored or shallow if the airway or respiratory tract is involved. Priority patient if a large body surface area burns or airway or respiratory tract is involved. Critical burns are apparent or burns involving hands, feet, face, genitalia, major joint locations. Do your physical exam. Alright, start at the head. Work your way down to the face, neck. Look for burns, singed hair, eyebrows, swelling of the tongue. Jesus, we just went over all this. Alright, blunt or penetrating trauma. If an explosion happened, check that out on the chest. Circumferential burns around the thorax, canopy ventilation, blunt or penetrating trauma to the abdomen and extremities. Circumferential burns reduces circulation. Blood pressure can be normal, high, or low. Alright, heart rate, normal or increased. Respiratory rate, normal or increased. Skin, normal if it's unburned or whatever the burn looks like. Pupils, normal. SpO2 maybe less than 94%. History, signs and symptoms. Skin that is pink or red, slight swelling, any kind of pain. Skin that is white to cherry red, moist, mottled, blistered, intense pain. Skin that is hard, tough, leathery, white, waxy, dark brown, charred. No pain in the burned area. They will have pain around the outside because all those nerve endings are not burnt. Okay? And we've already gone over this. Remove the patient, provide spinal motion restriction, open to maintain an airway, insert an NPA, OPA if needed. Bag them, put them on high flow O2, suction secretions. Estimate the body surface area using the rules of 9 or the palm. Determine the depth. First degree, second degree, third degree. Apply sterile dressings, bandages, or a burn sheet if the burn is less than 10%. Dress wet per protocol. Maintain their body temperature. Manage other associated injuries. If spinal injury is suspected, please mobilize them. Manage specific burns. Dry chemical. Remove affected clothing. Brush off the chemical. Irrigate with large amounts of water. Liquid. Remove affected clothing. Irrigate with large amounts of water. Burns to the hands and feet. Remove all rings, jewelry, dress between the digits. Chemical burns to the eyes. Flush with large amounts of water. Thermal burns to the eyes. Do not attempt to open the eyelids. Apply dry, sterile dressing to both eyes. Electrical burns. Carefully monitor pulse and respirations. Inspect for entrance and exit wounds. Assess for muscle tenderness. Apply the AED. You may want to go ahead and put the AED on these people. Like, I wouldn't be upset about it if they're still alive because they could have some, like, major issues going on. And, like, you can catch them pretty quick instead of, you know, if they go unresponsive in front of you, you can just automatically check the pulse. Lewis and feel for breathing. You already got the pad and stuff on. I wouldn't be upset with that. And perform reassessment every 5 minutes if unstable, and this is 15 if stable. I would go with 10 to 15. Alright. Bill cools the patient's burns with sterile water as Ariana completes the primary assessment, places the patient on oxygen to maintain her SpO2 above 94%. She then completes a rapid secondary assessment. Patient is alert, complaining of pain. She has some hoarseness and continues to cough. There's scattered bronchi and wheezing in the lungs, but it's difficult to discern whether they are related to the COPD or the burns themselves. The EMTs are concerned with the possibility of airway burns, so they begin transport without further delay. Medical direction advised transport to the closest burn center about 35 miles away. Well, they're pretty fucking lucky, aren't they? With a request for ALS intercept. En route, they dress the burns with dry, sterile dressings and continuously assess the airway, repeating vital signs every 5 minutes. Alright. What blew up?
Motor had gas on the piston.
Ain't that pain?
Yeah, it's good.
How long ago did that happen?